All right. Good morning, everybody. How's everybody doing today? Good, good, good. So I know I'm going to be the one in front of lunch today, so please bear with me. I'll try to make this interesting for all of y'all. Real quick, by a show of hands, how many of you guys are actually practicing in primary care right now? Awesome. And how many of y'all are familiar with direct primary care? Perfect. Okay, so for those of you who raised your hand the first time and you're in primary care, how many of you love rush clinical encounters, seeing 20 plus patients a day, dealing with multiple comorbidities and polypharmacy? How many of y'all love that? I saw a hand over there. Okay. We got a wild one over there. Of those of you who aren't in primary care, I'm curious, how many of you chose to avoid primary care for that very reason? Yeah. Somebody left primary care because of that. Okay. So I'm going to be honest with you guys from the beginning. My goal here is to hopefully motivate you, inspire you to reconsider. Those of you who have left primary care, those of you who are avoiding primary care, and those of you who are struggling staying in the fight, I hope to motivate you, inspire you to maybe reconsider as we talk about our role as PAs in transforming primary care by stepping into DPC. Now, as I'm talking, I realize I don't know where the clicker is. This right here? Is it this? There it is. All right. So, quick disclosure, I am the owner and the founder of a direct primary care practice, True Care DPC. I'm going to be using my practice as a case study throughout. What that means is I'm going to be mentioning some vendors that I work with, but I have no financial affiliation with them at all. In fact, I just owe them money so that I can use their stuff. Okay, so I'm not promoting anything here during this presentation. This is what we're going to be covering today. Like I said, my goal is to hopefully motivate and inspire you, and we're going to start by talking about what DPC really is, how it affects social determinants of health, and then in the hopes of showing you how attainable it really is, we're going to work through developing a roadmap. And the idea is you'll be able to download these slides, and you'll have what you need to get started should you decide to take up the cause. But before we do that, let's do a brief review of history. It was back in 1959 that the then Surgeon General, Dr. Leroy Burney, recognized that there was a severe shortage of medical providers that were available to provide essential medical services for primary care. And it was under the leadership of Dr. Eugene A. Stead of Duke University that our wonderful profession was born. And the first graduating class of physician assistants came out of Duke in 1967, right? And it is my belief that today's primary care crisis requires the same kind of innovation and leadership that birthed our profession in the first place. And I think that direct primary care is the natural next step for us. So, what is direct primary care? I'm going to start by first explaining what it is not. It is not healthcare reform. And I'll explain more of that in just a second. But we are not trying to reform what is. In fact, it's my opinion that our healthcare system is doing exactly what it's meant to do: prioritize shareholder returns. So we're not trying to reform that. It is not concierge medicine. This is a common misconception. DPC is not medicine for the wealthy. For those of you who may not know, because I didn't know, concierge medicine, you pay a high ticket price, several thousand, for the year that grants you access to the practice, and then they still typically follow a fee-for-service model when you actually go in to get seen. What that high ticket price does is it essentially ensures you're going to have access when you need it, rather than the typical long wait times that most primary care patients endure. DPC is not that. In fact, quite the opposite. It's all about creating accessibility. And I'll explain more of that in just a second. It is not insurance. This was explicitly stated in the so-called Big Beautiful Bill, which is important because this means that people can actually use their HSA accounts to pay for DPC services. It is not fee for service in any way, shape, or form. Importantly, DPC is not niche, cash-based clinics, right? We're seeing a lot of HRT clinics and, specializing in this or that and high-ticket items, functional medicine, that kind of thing. That's not what DPC is. Now, it happens that most DPC practitioners have a certain passion for a type of medicine that they like to practice, so many practices will take on that kind of personality, but that is not by definition what DPC is. This is a definition taken from the American Academy of Family Physicians. I've modified it a little bit for us here, and I'm going to read it to us, and then I'm going to walk through a few different pieces. So the direct primary care model is a practice and payment model where patients or consumers pay their clinician or the practice directly in the form of periodic payments for a defined set of primary care services. So what I highlight for us there is that word practice. There is also a misconception that DPC is just another payment model. In fact, where I'm coming from in Fayetteville, there are some clinics that advertise DPC, but they do not have that DPC philosophy, right? Fundamentally, those of us who start direct primary care practices have a conviction about what our patients are entitled to in primary care, about what it should be. We really do believe that primary care is where the rubber meets the road. That's where we keep patients out of the emergency centers. That's where we address lifestyle factors that contribute to complications of disease. And we want a model that allows us to practice medicine that way. So it is not just a way to get paid. Some people are under that misunderstanding. You'll also see that in DPC, our patients contract directly with either the clinic or the provider. Now, if you work for a traditional clinic, you may or may not know that typically the practice has to contract with the insurance companies, and they have to negotiate reimbursement rates and all that kind of thing. Fundamentally, what that means is that the real clients are the insurance companies, right? Well, in this setting, that's not the case. Our shareholders are our patients. They are the ones that contracted with us. They are the ones that we negotiated with, so to speak. So it is very different from what people are used to. Lastly, it is for a defined set of primary care services. We'll talk a little bit more about that, but when we set up a DPC, we're able to communicate with our patients expectations and what we're able to offer them on the front end. So we remove a lot of the ambiguity that may exist in our current primary care practices. So what DPC does is it straight up sidesteps the traditional healthcare system. Like I said, it's not reform. We're not trying to fix something. We're just not playing the game anymore, right? We don't want another party in the room, the insurance mafia, dictating what we do. It restores the clinician-patient relationship. For me, there was something miserable about working at a traditional practice where it's very transactional, right? Hey, how you doing today? Are you current on your meds? Let's refill those. Are you due for labs? Do you need any referrals? Because that's all we have time for. DPC eliminates that and restores the humanity of medicine. We'll dive into this further as we talk about how DPC affects social determinants of health, but this is important, is it offers transparent, upfront pricing. From the get-go, your patients know what to expect. It gives your patients direct access to you. Now, on the surface, that may be a little bit intimidating. I know a big concern. What do you mean they're going to get my phone number? I'll briefly point out to you right now that I have been at this conference since Sunday with my family. This is the third trip we've taken this year as I'm running this practice. So, it is very possible to set boundaries while still granting your patients direct access to you, and we'll talk about how we do that. This is a big deal for me as someone who likes to talk. Longer, unhurried visits. especially when you have patients who haven't seen a primary care clinician for years, right? And they're trying to remember what the name of the medication is based on the color and shape of the pill, right? Having that extra time, essential. The next two are hands down my favorite. In DPC, you intentionally maintain small patient panels. It's hard to have time if you're overwhelmed with a large census. Real quick, by a show of hands, how many of y'all have a census more than 1,000 patients that you're supposedly responsible for? God bless y'all. In a typical full DPC practice for a single practitioner, and this is if you want to work that much, 500 to 600 patients is what you'll have for yourself. Lastly, this is another one of my favorites, minimal administrative overhead. Y'all don't understand how big of a deal this is for me, right? Because of the simplicity of it all, because you remove the bureaucratic red tape, you do not need multiple levels of administrative support, which then raises costs and just complicates everything. So here's how it works. It's actually quite simple. The patient contracts directly with you or your clinic. When I started off, it was just me. So that's what they signed, was an agreement between themselves and me and what I would offer, right? I would set the expectations of what that fee covers, and if they liked it, they signed it, and we got started. For that 1 monthly fee, they got all of the comprehensive services that the appendix of the agreement lays out, routine visits, acute care, any skills that I have to offer. At the time, because of where I was starting, that was limited. And I would update that agreement on a regular basis as my skill set and my resources increased, right? And that was all part of the once-a-month fee. And then, of course, they would then get that direct access we're talking about and those longer appointments. Let me show you how DPC stacks up against fee-for-service. So, of course, it varies between practice, from practice to practice. That's another thing. If you've seen one DPC clinic, you've seen one DPC clinic. You don't know what the others are like. But here's my experience, how I've set it up. I see about 6 to 8 patients a day. 8 is a busy day. When I'm getting ready to go to a conference and I know I won't be available, I might do 10, right? That's a busy day. Time per patient, that 30 to 50 minutes includes the time I'm talking with the patient, writing notes, sending referrals, and that's a personal preference. Like I said, I like to talk, I like to spend time with my patients. A lot of that time often is spent catching up. Again, restoring that human aspect to medicine. Admin time is minimal, still got a chart, but the fun part about that is the charting is for you. It's for you and it's for your patient. It's because you actually want to keep record of what you've been doing, and it's going to serve them well if you need to refer them in the future. Clinical autonomy is huge, right? I mentioned not having a third party. There's something special about being able to have a back and forth when we talk about informed decision-making for your patient, shared decision-making, and not having some voice in the back of your head telling, but will the insurance cover it? Will the insurance cover it? Will they compensate you for it? Are you going to get reimbursed for this extra time that you're spending? How are you going to upcode for this extra time or the skill that you employ? That's out the window. It's you and them, because that's already covered in the once-a-month fee, right? Job satisfaction is objectively higher according to the survey by the American Academy of Family Physicians. They compared family physicians who did DPC and those who didn't, and they marked much higher in job satisfaction those who are in DPC. Financial pressures, much more stable and predictable. There is no guessing whether or not the person that you're billing is going to decide that the work you put in is worth it. They're not going to be able to dodge or deny a claim, or you have to resubmit the claim and you don't know when that check's coming. That's all out the window because you have a monthly membership. And then my favorite really is the fact that I have ongoing and personal relationships with my patients. I literally have had patients make quick appointments just to let me know that that person they were engaged with, they're now scheduled the wedding. They're so excited that we got their blood pressure under control, and they just wanted me to know how all that was going. And that's amazing to me. Here's how it compares to fee-for-service, right? Again, 20-plus patients. If you've ever been interviewed for a job at a primary care clinic, that's what they want to know. Can you handle 20 patients a day? How do you feel about 25? What about 30? That's what they want to know. 5 to 15 minutes allocated time. We know the reality, right? Because they got to get screened up, and there's going to be delays, and they're going to stack on top of each other. So 15 is being generous, but we know what's really going on. A lot of admin time, again, because you're meeting those insurance requirements. Limited autonomy, because you're working for somebody else. And job satisfaction is low. And if you were to be somebody who runs a practice or be behind the scenes on the financial pressures, I'm telling you, I did submit claims initially with TRICARE because I'm in Fayetteville and that's, the military. And I'll tell you what, that lasted for a month. That lasted for a month. So now I do super bills instead for my patients, and that's easy to do. And then, of course, I call it Burger King medicine. Fee-for-service to me is like Burger King medicine. How you doing? Can I take your order? What do you want? Because we got to get this moving, right? That's what it's like in fee-for-service in my experience. And I see a lot of heads nodding, so I know I'm not crazy. So here's how it works at TrueCare GPC. We are a family and sports medicine clinic. I started in the Army. I got a lot of ouchies, and so I got really good with musculoskeletal stuff. So I offer exercise therapy, dry needling, manual therapy, these kinds of things. All of that is part of one monthly service fee of $99 for adults and $25 for children. And then the patients, like I said, they contract with the practice now because now I have another provider on the staff. So they contract with TrueCare. The patient chooses their provider, and that's who they get assigned to, and that's the phone number that they get is for that provider. Our patients, they get those unlimited 30 to 50-minute visits. The $99 a month includes 3 routine lab panels a year and over 1,000 generic medications that are shipped directly to their home 6 times a year. No additional cost to the patient. They don't need to run their insurance whatsoever. That is part of the $99 a month for adults, $25 for kids. And I am spending approximately 30 clinical hours a week. Again, that includes the charting, the referrals, the follow-ups, and things like that. Right now, my scheduled clinic time is Tuesday through Thursday, and Monday and Friday are flex days for me. I will see some patients occasionally, but a lot of that is for building things like this so that I can do these other things that I enjoy doing. Now let's talk about DPC and social determinants of health. So here's a problem. Traditional insurance-based care has barriers, right? High deductibles, co-pays, surprise bills. And I don't know if you know this, but that is behavior modifying activity. It is intended to reduce the use of healthcare services. Again, I don't know if you're aware, but insurance companies make money by not paying, right? And so if they can discourage patients from using services by raising costs, they will. Something else that they do is they narrow their networks. You guys may have heard of some of the controversy over the last year or two as some big insurance companies are buying up practices, taking more and more ownership about what clinicians are doing, narrowing the options for the patients. That's going to increase wait times. In Fayetteville, because the reimbursement rates keep dropping and the network keeps getting more and more limited, patients, service members, and their families are waiting months and months and months to establish care in primary care and in specialty services. And that's intentional. And of course, this is going to exacerbate accessibility, especially in rural and underserved areas where they already have limited primary care. So, what's the solution? DPC. Because DPC offers economic stability for our patients. It is fundamentally cheaper to run a direct primary care practice, which means that we can offer our services at a much more affordable rate and in a predictable manner, right? My patients, how much does it cost? Here's the price. Let me earmark that in my budget. Now I know I have access to primary care. And I know I have access because I have his phone number right here. The extra time that we get allows us to help patients navigate the complicated healthcare system. Because the truth is, right, no matter how involved you are, no matter how holistic you might be in your approach, there are simply things outside of our scope. And that we run the risk of getting fragmented care. Well, when you have the extra time that you can dedicate to these things, we reduce that fragmentation. Because of that cost that I already mentioned, the low cost to operate, we can actually address the physical environment and operate in places where normally reimbursement rates are prohibitive, where it just doesn't make financial sense for you to start a practice somewhere because you can't make a living. But because it is inexpensive, and I will show you just how inexpensive it is, you can start a practice in underserved and rural areas and still make a living, provide for your family, and build a practice and change your community. My favorite thing is that as a DPC clinician, having that flexibility, that predictability, and that time allows me to address health literacy. It is a tragedy, and I'm serious when I say this, that I have patients in their 50s, in their 60s, who have been managing chronic diseases for decades that tell me that I am the first clinician to ever take the time to explain things to them. Why? Is it because my peers don't know what they're doing? No, because 5 minutes is not a lot of time. But when I have 50 minutes and a whiteboard in my exam room, I can literally draw it out for you, right? And that to me is invaluable. And what I've seen with my patients is tremendous buy-in. And that's important. Now, how does this impact health disparities? Again, it removes financial and administrative barriers, which unfortunately are disproportionately affecting those who are of low income or minority status. One of my favorite things to see, I have patients who are concerned about their legal status. They're worried about if they put their information down here, there, and the other. Hey, this is direct between me and you. Let's just take care of you and your family's needs. It gives us the freedom, like I said, to choose to serve in underserved areas much more easily. And again, I've already harped on this. It gives us this time to address even financial literacy, nutrition, and exercise. I have time to teach my patients how to exercise. I have weights in my clinic, literally teaching my 50, 60-year-old patients how to lift weights for the very first time. I have had patients tell me the reason I couldn't do X is because I can't afford it. Well, then in your follow-up, we're going to spend 50 minutes talking about how to form a budget. I have time for that. I don't have to worry about that because it's about you and your care. At True Care, our membership for a family of 4 is about 5% of the median household monthly income. And compare that to the average American household, which spends about over 8% of their income on healthcare annually, and that again comes with the red tape and the bureaucracy. Our patients, they get the unlimited access, they get the extended visits, they get the education, and they get the direct communication at what I think is a very affordable cost. So with that, hopefully I have y'all's attention. Hopefully I have a little bit of inspiration in the room. Now let's show you how feasible this is, and let's start working on developing a roadmap. We're going to go over financial steps and operational steps. These are the financial steps. We have to consider our startup cost, revenue planning, and then we also have to address our personal finances, right? When it comes to operational steps, we're going to talk about forming your entity, your professional entity, insurance, technology and EMR, as well as a marketing plan. And don't worry, the plan here is to make it attainable, right? Make it something that after today won't feel so overwhelming. Let's start with our financial steps. A lean direct primary care practice usually requires around $5,000 to $50,000 of startup capital. I really want to emphasize $5,000. Now that's not nothing, but we're talking about starting a comprehensive primary care clinic in rural underserved areas, addressing health disparities. For $5,000, I think that's a pretty good ROI. If you focus on the essentials, that really is a reality. That's not pie in the sky type stuff. Your essentials, your major expenses, a basic office lease, your malpractice insurance, an EMR, a little bit of key pieces of furniture, a website, and some marketing. Let me show you how it was for True Care. I estimated, looking at those things I just said, that I would need to get started $4,200. What I ended up needing was $2,038.24. I got receipts. And I paid that through some savings that I had and a GoFundMe that I started that doubled both as a marketing campaign and as opportunity to gain some funds. Marketing, because I was announcing to the community, that's what this is. This is for the community. You can sow into it if you want, or you can share this. And that was part of a plan to also increase the awareness that this was coming. I networked for a free space. My first space was completely free, no rent at all. It was inside of a jiu-jitsu gym, an 8x8 room that my dad and myself and a friend built over the weekend, Friday to Sunday. In exchange, I agreed to provide primary care services to the team that was in that jiu-jitsu gym. Anytime they needed anything, they just texted me, I took care of them. I was gifted a massage table as my first exam table. And then I purchased equipment as my panel, and then my revenue grew. I used Atlas MD for the first month for free, and that's simply because my mentor, Dr. Niti Kapoor, she offered to let me scribe for her in exchange to help me get started and teach me the ropes. And she happened to have Atlas MD, so I knew how to use it, and that was really the only incentive there, the only reason why I chose that. I paid $407 a month for liability insurance, and that's because the AAPA had put this little ad that you get some sort of discount, and I was trying to save some money. I paid $12.99 a month for web hosting through Canva. By the way, I'm not savvy when it comes to website design. I've been using Canva for a while. They have wonderful templates. Everything uses AI to support you. And there's other tools now like Wix and Squarespace and things like that, all at affordable rates to help you get started. And then I spent a grand total of $45.02 on marketing flyers, business cards, and a small Facebook ad. This was TrueCare DPC when we got started. I had no signage. My favorite thing was having people walk up scared, like, am I in the wrong place? I'm about to get mugged, what's happening? I'm not here for jiu-jitsu. And I'd come out and be like, no, it's me, I got my stethoscope around me, you're in the right place. And this is us building it. That right there, that little box, is where we accepted the first patient on January 23rd of 2024. That's where we saw each other. For revenue planning, you want to think about your membership pricing. You would do a little bit of a market analysis, but typically for GPC, 60 to 100 is the general range. Of course, it depends on the area that you're in. Some of those are as low as 40. It varies. Some people use tiered pricing for age differences when they anticipate that different age groups may have higher needs, things like that. You'll do a break-even analysis, asking yourself how many members are you going to need to cover the cost? It's a very practical question, right? Then, how many members would you need for a modest salary, right? And lastly, how many do you need for a sustainable salary? Basically, you know, when we work for somebody, a portion of that check is meant to fund dreams, right? Meant to fund the future for the family or something else that you want to do. So that's what that question is asking. How many members would you need so that you can finally take a piece of that check and start dreaming with it? I think that's a reasonable question to ask. For some context, conservative planning estimates are that, on average, to get to a full panel of 500 takes 21 months. Now, that's an average, right? So that means that some people are going to do it faster, some people are going to do it slower. We're at month 20, and we have 235 today. You'll see the slides here are a little bit outdated because I submitted them earlier, but we're a little slow. We're doing good. I will say, we're at the sustainable salary point, so I'm happy about it. So, for our revenue planning, $99 a month per adult, $25 for child, I estimated that I would need 59 members to cover the cost. It turned out, when I made that estimation, I didn't know I was going to get a free space. I didn't know I was going to get stuff donated to me, right? So, it turns out I actually only needed 23. And I got to 23 members on month 3. So by month 3, the practice was paying for itself. I was no longer failing to feed the 4th kid in the family, and I could now take it from, that's a joke, y'all. They're all well fed, I promise. I recouped the initial investment of the $2,000 plus the operating costs within 6 months. Which again, if you're not familiar with how business works, that's a pretty good timeline. And like I said, when I submitted this back in June, we were at 208. We are now at 235, I checked this morning. Our approximate revenue at this point is closer to $18,000 a month, and we are profiting $6,000 a month right now. Now let me give some context to that. When I say we're profiting $6,000, that means that my salary is paid. That means the business costs, the fixed overhead costs are all covered, right? So that $6,000 is what we're using to reinvest, but it is optional. At this point, we are at a point that should we choose to just hold what we got and let everything be organic, not spend on marketing, not give any raises, this is what we would be as a practice leaving as profit. Oh, and my favorite thing, plenty of family time without worrying about paid time off. It's a big deal for me, probably my favorite. So this graph shows you, starting in January, that growth really isn't linear. It starts to become more exponential as you gain because there's more word of mouth. There's greater awareness as you create content, as your online presence grows, as you improve your search engine optimization, so too the memberships follow. There is a kind of tipping point that happens where this slow trickle effect starts to take off. It's a very real thing, and it's very neat. For our new provider that we have on staff, she is about to hit that point, Lord willing, in the next month. And then this is just depicting the way our revenue has grown. In January, our revenue was $8,400, and at the time, this was $17,500 for June. The point of this, by the way, I'll remind you, isn't to brag. It's to show you guys that this is feasible. All right? It's to show you that this is real. And I want to pause to emphasize something that may be lost on you. Fayetteville, North Carolina is considered the center of the universe for the military, okay? For the Army, at least. A huge portion of the population has insurance. And outside of that, because of the Medicaid expansion, those who didn't before now often do. And in that setting, this has been the success of our practice in 20 months. Because this is the kind of value that DPC offers the community, not just us as clinicians. All right, for your personal finance prep, because we are talking about stepping into business ownership, entrepreneurship, you do have to make sure that things at home are squared away. So you want to budget for a slow ramp up. I'm an optimist. My wife will tell you. I thought I was going to be ready to go in 3 months and take off, so 20 months is a lot slower than I expected, but thanks to my wife, we budgeted for a slow ramp up, all right? You do want to maintain your own personal overhead, keep that as low as possible. So what I'm talking about is that standard of living. If this is something that you see yourself doing, you may have to look at your current spending patterns and say, well, while we do this, this may have to hold. And that's just to make sure that you have a safety net. That's just to make sure that you are not anxious about where the money's coming from as the practice grows. For us, we had established an emergency fund, and then we calculated all our revenue streams. Like I said, I have some ouchies, so I get VA disability. My wife, she has some income. She's a real estate property manager in the area. And I was working part-time when I got started. So we add all that up. How much are we making right now? And then we asked ourselves, how do we want to live while we do this? And this is a personal choice. There's not a wrong or a right answer here, okay? This is where we decided we don't need to buy this, we don't need to go out as often for that, we probably won't travel for the first year for this and that, and that's just, again, to give us that safety cushion, right? Okay. Next, let's talk about operational steps. You choose your appropriate entity. This is pretty straightforward here. In North Carolina, we can own our own medical practices, and all the steps are published. And it's actually pretty neat. The North Carolina Medical Board really does do a good job of providing you those steps. As long as you kind of pause for a second and read through carefully, that's what I did. And like I said, it was fairly straightforward, just like they said it would be. You're going to want to identify your collaborating physician. So some of you guys, you might be already thinking about who that is. We'll talk about briefly in just a second what to do if you don't have that. So for us, we established a PLLC, again, following those simple steps online. And I actually contracted with Doctors for Providers for my collaborating physician. This is a third-party service. There's a few out there. A lot of those are geared mostly towards nurse practitioners, but Doctors for Providers was very PA-friendly. And that was a pretty simple, straightforward process. They do an interview. I gave them my CV. They found a physician that they thought aligned with what my goals were, set up interviews between me and them. After speaking with two, we decided on one, and we moved forward. And we just included that cost in our monthly expenses. For malpractice insurance, there are some things on the market that advertise as DPC friendly. I don't know a lot about them personally. Like I said, I went with CM&F Group just because of that special that was being offered. For EMRs, there are DPC optimized EMRs. A lot of the current EMRs, their primary focus is billing. Right? They're trying to streamline charting for the purpose of billing. These EMRs listed here are specifically for DPC. They don't have a lot of those bells and whistles that you do not need, right? That said, they specifically are set up to integrate well with like labs and faxing and charting and things like that, what you need to really run a DPC practice. For communication, because you are going to have direct communication with your patients, you want to have something set up for HIPAA-compliant messaging, right? There are services like Spruce. Google Voice has a commercial version that you pay for that when you sign an agreement, you can set it up to be HIPAA-compliant. There's also Doximity and other platforms. For us, we went with Atlas MD, like I said. I use Doximity for eFax. It's completely free. It's very reliable. If you're not familiar with it, you just doximity.com, and they have it right there. They assign you a number. You create an account. Very simple and straightforward. We use Google Voice with the Business Associate Amendment that makes it HIPAA compliant. And we do communicate with our patients. There's a clear explanation. Hey, because we're going to be doing this back and forth, there's that risk there. Do you accept that? Some patients don't accept that, and all communication is limited through the EMR, which sets up a whole different kind of protection layer for them. All right, we're almost getting to the end here. We'll talk about our marketing plan. Here's the thing. I want to say, when it comes to success in running a business, one of the most feared and often underestimated portions is marketing. It doesn't matter how good what you have is if people don't know about it, right? So this next part, I hope to make it not only very useful, but also alleviate some of the stress and give you some clear direction so that when you leave today, you don't feel overwhelmed with the marketing portion, because it is important, and I think it can make or break. So building a pre-launch audience is a useful strategy. Like I said, we started with GoFundMe to get the word out there. Creating email lists, generating attention from people. Pre-enrollments is a strategy that is often used and is found to be pretty successful. And it helps to build anticipation. People start looking forward to the opening of the practice. An online presence. That's, in my opinion, a non-negotiable, because that's where people are mostly going to find you. They're gonna look online for a primary care practice, so you want to be on there. There are some simple search engine optimization basics that you can learn a lot about on YouTube, and you can look up DPC keywords that will make you easier to find. I've had patients find me through ChatGPT when they were looking up, yeah, I want a holistic primary care, and Chat recommended us. Social media. Now, social media, I'm sure you guys know, always very divisive topic. Some people hate it, some people love it. I'm of the belief that it is useful for us. You are not trying to be the next influencer when you use social media. You're not trying to go viral, right? All you're trying to do is use a platform where many of your future patients are already residing, so you can share information with them and show them the value of what you're bringing to the community. And then there's always, importantly, that grassroots outreach, attending local events, the health fairs, partnering with gyms and churches and other organizations that are doing these kinds of outreaches that maybe y'all have already participated with in the past. For us, I created a Facebook page months in advance before I intended to take on my first patient. and I announced that the practice was coming on YouTube. And again, this was intentional with a lot of language that was geared towards Fayetteville, Fayetteville primary care, holistic care, all terms. I used towns that were local to the area when I was speaking and my captions, things like that, so that if you Google that, you're more likely to find that image, right? And Google is related to YouTube, by the way, so that's an important strategy. Oh, and in case you're worried about how you look on video, I can't tell you how terrible the quality of the original videos were. They're still up because it creates, that presence, but you do not have to be into videography. You don't, I'm telling you, it doesn't have to look clean cut. It just has to be authentic. I created my website with Canva. I swear to you, I didn't know anything about developing a website. So I just clicked this icon, I liked where it was, I centered it. I typed some words in and I pulled up another DPC practice and I was like, I like this about it, I don't like that about it, let's put that in there. And then it has a button that says launch your website and boom, there it was. Very straightforward. I established a Google business profile. That one, there are steps that you have to follow, and you have to watch the prompts, but if you can find a time where you're not feeling rushed or pressed and follow those instructions, it is a bit intuitive. A big thing of what we did to grow is we asked for Google reviews. For every single person that came by, whether it was for a consult, for a sports physical, or a new member, regularly asking for reviews, making the link accessible to them, texting them a follow-up, thank you for coming. A 5-star review would be great. My favorite little joke to tell them gently was, 5-star reviews are great. If you have nothing good to say, then just keep it to yourself. I think they believe me because we're at 72 5 stars so far, no bad reviews, so it's doing something right. And then I did attend a lot of local events. Just getting my name out there, shaking hands, handing out business cards, standing awkwardly and uncomfortably, sweating through my shirt. Hey, I'm Goldfron. I have a DPC. What's DPC? Oh, I did that, and I still do that. I don't sweat as much, but it's still a little awkward. And then social media content using trending audio. If you're not familiar with it, if you pull up something like Instagram and TikTok and you record something, the app itself makes recommendations. You don't have to sit there and calculate whether or not this is where you go big. You just pick the sound you like, right? And if you're talking, lower the volume on the sound that you're adding, and so that you can be heard. But I'm telling you, I'm not a social media influencer, but I've had a few views here and there. No big deal. All right, here's some considerations as we get ready to close this down. I think it's better that you start solo or with very light staff. I think one of the things that really gets in the way for people is you're picturing the practice you're currently in or you were previously in, and it's hard to imagine how you could start something like that. You're not starting something like that. You're starting something completely different. And again, it could be inside of a jiu-jitsu gym. It can be in a wellness spa. It could be a suite inside of a mental health clinic, right? Whatever works in your community, start small. Your membership agreements. A big concern that people have, and I'm sure I'm going to get this question, with that direct access, how do you ensure that you're not on call 24/7? Put it in your agreement. Our agreement explicitly states Monday through Friday, 8 to 5 are office hours. You can expect us to reach back out to you within those times. If I cannot, give me 24 hours to get back to you. If I have not gotten back to you in 24 hours, text or call me again because I probably read it and didn't respond. If you text me after those hours, I cannot guarantee that I will get back to you in that time, but I'll get back to you as soon as business hours start again. And again, I have patients that text me outside of those hours, and guess what? If I'm busy, I do not respond. If I'm not busy, I respond. Your office policies will also be laid out in that membership agreement, and this is where you set your boundaries for yourself. This is where you learn to communicate to your patients what their experience is going to be like. You set those expectations, that predictability, reducing that unknown for yourself. Now let's close this out by evaluating some realities. Okay, so there are some common challenges. Slow, early growth is a real thing. It does take time to build this out, right? Again, even the best ones can take up to 1.5 years to be completely full. That's true. And sometimes that can be disheartening. I didn't put this in here, I don't think, but with that slow growth, what happens is sometimes patients leave. Not for any other reason, but they moved away, their finances changed, their priorities changed, whatever. That happens. And that might sometimes feel like things are slowing down. That's a reality that we have to be emotionally prepared for. A lot of people are unfamiliar with DPC. Even in this room of medical practitioners, I only got a few hands up regarding DPC. And usually when I have someone tell me they do know what it is, they then go on to describe concierge medicine. So a lot of people are unfamiliar with it. And that is a challenge. But we can address that with constant messaging and patience. It's a little isolating at first. I'm a bit of a social butterfly. So when I didn't have patients, I had 1 member or 2, and I was in that jiu-jitsu gym, I would just roll around. I'd death scroll, be lonely, text my wife, hey, how you doing? What are the kids doing? It's a little lonely at first. Now, we have a facility that's 3,000 square feet. I have a mental health counselor who subleases one of the rooms, and a massage therapist who subleases another, and a nurse practitioner who's running her own panel, and a medical clinic director, and I hang out with everybody all the time. Financial risk. You do get the upside, but you also get the downside. There is no guaranteed paycheck, and that's why that personal finance piece is essential. Right? For me at the beginning, you can imagine my relief when I finally got my wife on board and I said we were going to do this thing, and it was only 3 months in where now the practice was self-sustaining, right? But there is no guaranteed paycheck in the front end. This is business, and sometimes things don't go the way we plan. You will be responsible for everything early on. And that might seem overwhelming, but if you did what we talked about with your agreement and your office policies, you build the plan in from the beginning. But it's still true that you will be the one who starts off doing the scheduling and the communication. But with that does come the advantage, right? Where you don't have that surprise patient or that patient that canceled so you thought you had more time, but then when you refresh the screen, the MA squeezed somebody else in on you. You don't have that anymore. So there's advantages and disadvantages with that. You are going to be the one doing the marketing in the beginning, most likely, if you're keeping it lean. But the major benefits, mission alignment, to me is a big deal. You get to directly address healthcare access gaps, and you can restore what I believe is the ideal of primary care. Clinical autonomy. Total freedom, within reason, to practice evidence-based, patient-centered medicine without a third-party interference, and deep patient relationships. I don't know about y'all, but I think one of the beautiful things about practicing medicine is the human connection, and we get to have that in DPC. More time with our patients, and in my opinion, and what I've seen, stronger therapeutic alliance. Job satisfaction is huge. I find myself saying what I've never said before, and this might be unique to me. I am doing the work that I choose to do, that I want to do, and that I love to do. And there is financial upside, okay? Yes, there's risk here. Yes, it's a business. Yes, there's no guarantee. But if you do this well, you focus on value, you focus on being the provider that you're supposed to be. Once that panel builds, the income, without dealing with insurance, there's really no limit. And my favorite thing is the lifestyle control. I'm here by the grace of God and because of the support of the patients that I serve. My patients literally funded for me to be here, to spread the word. When I announced to them that I was coming here, I sent them an email letting them know. I had so many of them respond back, congratulating me and thanking me and supporting me. Some even asked for the link. And that's an amazing way to live, in my opinion. So here are some lessons learned so far. Persistency does pay, okay? If you're consistent, it will pay. Flexibility is key. Relationships are more important than advertising. And those who are lean and disciplined they win. So, here are my closing takeaways for y'all. In my opinion, DPC is an incredible model for practicing evidence-based medicine, building real patient relationships, and doing it without compromising your integrity or your sanity. You get to be the PA you were trained to be. We were trained to listen, we were trained to lead, to treat the whole person, and DPC gives us the space to do that and the freedom to do it well. I don't think the system needs fixing. I think we need a sidestep, and that's what DPC allows us to do. The time is now, y'all. If you've ever said, there has to be a better way, this is it. And if you've ever thought, I could never do that, you absolutely can. If you're waiting for the perfect time, it's already here. Thank you.
Thank you. All right, we have tons of questions. Okay, a lot of them that overlap, so I may wind up going a little bit more than what the question just asked, because I know that there's other questions involved with it, okay? How does DPC work for referral specialists? Will patients still need insurance for specialists, medications, and imaging?
So the answer to the question, will they need insurance for specialists? Yes and no. So more specialists are offering direct pay options. In Fayetteville, there are some who have published their cash pricing, so patients can budget. But for the meantime, for the majority of practices that are billing insurance, they will need that. For medications and imaging, it depends on the practice. Right now, our goal at DPC is to get to 275 members. If we can do that, we will be able to afford covering routine mammograms, ultrasounds, and chest x-rays as part of that 99. So it does depend on the practice itself and where you're at.
Okay, next question. What is included in the routine labs? How about if you need more expensive labs like hepatitis, HIV, viral load for high-risk patients? How do you manage poorly controlled diabetes with just generic meds?
Awesome questions. So with labs in general, I go through a healthcare procurement organization that has helped me get a contract with LabCorp for steeply discounted labs. So routine, CBC, CMP, TSH-T4, a lipid panel, and a urinalysis costs the practice about $15. For more expensive labs, like a full STI panel, including HIV, it's going to be about $150. For sex hormone studies, which many patients are interested in, even those with insurance, that's $72. So when you use these kind of networking resources, it's actually very, very affordable, and you discover a lot of that expense is due to other players involved.
Okay, I think the second part, how do you manage like a poorly controlled diabetic with just generic meds? Yeah,
so in that instance, we do lean on our pharmaceutical reps who offer us samples. There are programs as well and coupons. There are state-funded coupons that help us. That does present as a challenge. What I will say is that when we don't have the newer medications, what we really drill in on is the lifestyle modifications, which we now have time to do. Right? We now have time to address nutrition confusion. We now have time to teach how to do exercise, which are evidence-based, and we know that they work, right? We know that even some of the newer medications, the way they were studied depended on dietary changes and exercise. There are limitations there for sure, but I find that we're successful working around it.
Okay. What are some of the downfalls of DPC?
Ooh. So this idea that you wear all the hats in the beginning is real, and it is challenging. And it is stressful. Something I tell people that I didn't mention here, you have to have systems in place for yourself to take care of your mental and physical well-being as you're undergoing that. So that does require a level of discipline. Another thing is, when some patients do come and go, especially in the beginning, when I tell you that that is disheartening, it really is. I'm not going to lie to you, because you spend this extra time with them, you plan for this to be a relationship, and then they leave. It feels a little bit more personal. The biggest downfalls or downsides to it I think are going to be the same things that are true of any business, right? You have to get your name out there. You may struggle to communicate your value to customers. It may seem like a no-brainer to you, but the market that you're in, it may require a little bit more education. And so those are some of the things that I don't think is unique to DPC, but is worth considering.
I love primary care, but I was abused by the medical system I work for. How can I find a DPC clinic to practice?
So there are actually Facebook groups specific for nurse practitioners and PAs that are in the DPC space. There's also the DPC Alliance that shares, like if you want to work alongside physician-owned practices, they're listed there for the whole country. And if you're in Fayetteville, I'm always happy to talk.
Next, how about the cost for EMR, malpractice insurance, and cost for the patients if they need hospitalization? I think those are really two different questions.
Yep.
Yeah.
So I can't speak to the other EMRs outside of Atlas MD. For Atlas MD, I pay $300 a month per provider, and that includes the ability to prescribe. There's no additional cost for prescribing narcotics or anything like that. Like I mentioned in the slide, the malpractice insurance, that's my current rate that I'm paying is $400 and some change. So you have to shop around for that. Obviously, vendors are excited to talk to you about it and talk about your different rates. What I will tell you is just keep in mind you don't need the bells and whistles. You just need what you need to chart and be able to keep track of what's going on with your patient's care. As far as what your patient needs for hospitalizations, DPC pairs wonderfully with high deductible health plans, where if they, basically it serves as catastrophic insurance for them, right? Whatever that deductible is, and you have this conversation with them about saving for that deductible, and then if anything ever comes up, they're covered, right? They pay that deductible, and then the rest of the services are covered.
Are the 8 patients today that you're seeing pre-scheduled annuals or follow-up visits? What do you do if somebody calls in with an acute or sick visit?
It's a combination. So the 8 patients today, it's a combination. It's establishing care, it's follow-ups, it's screening. It's a combination of all kinds of different things. I build into my schedule windows of time for acute visits. Like I mentioned, Monday and Friday are my flex days. The reason I set them up that way is because most instances, unless it's severely acute, I can touch base with them via phone, right? I already know them personally. I know their baseline. I know their medical history. I know their comorbidities, and we can start developing a plan. If I'm really concerned about it, I'll have them come in the same day or the next day, right? But that's just part of my rhythm and how I set up my schedule.
Do you ever tell a patient if they're sick, no, I can't be seen today, my schedule's full?
Absolutely, all the time. No, not at all. The most screening I do is let me get on the phone. I do find that sometimes patients are more concerned, than clinically indicated, and so getting on the phone with them a lot of times puts them at ease, and then offering them that come in tomorrow to make sure everything's okay thing goes pretty well with them.
Okay. How many staff members do you have?
So technically right now it's a total of 3 of us, myself, the nurse practitioner, and the clinic manager. And that started in June of this year.
As you are starting up the new practice, are you still able to work full-time? For example, I'm currently off on Fridays and would look at working Friday, Saturday, and Sunday evenings if needed.
Yes, absolutely. That was the same thing with me. And then I slowly took a day off from the work week to then focus on the practice, and I would just kind of take a day off. I did end up moving to a different position that paid more for less hours. So I went from a primary care to an urgent care to facilitate that. But yes, there was this incremental, gradual progression. There was a moment for me where I had to take a leap, where I was like, okay, this next month has to follow the trajectory, otherwise it's gonna be rough. But we did cover that in the budgeting aspect of things as well.
Do you offer any in-home visits for some of your patients if they have difficulty getting to you, or for instance, if you were doing a newborn visit?
I have done that in the past. It's not something that I advertise, especially now more than ever where I have more patients. When I started, that was pretty normal for me to do, and that was just a way to communicate the extra level of value that we offer in DPC.
Do you require your patients have catastrophic policy? Oh, we talked about this before. And what about imaging studies?
Right. I don't require them to do anything, but I do counsel them on that, right? I do explain very clearly what this is not. In the agreement, it explains we do not cover anything outside of the clinic. So that is a conversation that we have, and I think I already addressed imaging as well.
I worry about being on 24/7, including holidays. It sounds like you hired another provider. Was that why?
No, I hired another provider because I wanted the practice to grow without me having to take on a whole bunch of other patients. So I mentioned building in your boundaries, But, you know, ideally, we do have peers, friends in the area that we trust to see our patients. So I started taking my first trips last year, and that's what I would do. I would reach out to a fellow PA, let them know what was going on. I'd communicate to the patients well in advance, give them their communication, set them up for the EMR, and it was nice and easy. And I took care of any routine things, like any prescriptions, any referrals that are still floating around, got all those done ahead of time. And I still would get an occasional message here and there that was just kind of a check-in on something, and I might reply. But while I've been here, I get messages from people who don't read their emails, and I say, hey, go ahead and reach out to the nurse practitioner, should take care of you. And the patients are fine with that.
Okay, and I know we have a ton of other questions. We'll let you answer those offline. But
Sure.
Thank you. Thank you for your talk.
All right.